Hello everyone. Today we are going to discuss walled prolapse, a condition that holds important clinical relevance for gynecologists, especially in the post-hysterectomy population. First, let's begin with the definition. According to the International Urogynecological Association and the International Continence Society, walled prolapse is defined as the descent of the vaginal wall after hysterectomy, where the cuff scar descends below its normal anatomical position, sometimes protruding outside the introitus. The core pathophysiology is Delancey level 1 failure. It is the root cause. If the uterosacral or cardinal complex isn't re-anchored at hysterectomy or weakens over time, then the apex descends. After that, anterior wall and posterior wall descends. That is why prevention of walled prolapse is best done during the time of hysterectomy. At vaginal hysterectomy, macroculoplasty reduces the post-hysterectomy walled prolapse and enterocoel. At any hysterectomy, reattach uterosacral and cardinal ligament to cuff. The scar is prolapsing, then there and there do sacrospinous fixation. How to do the clinical evaluation of the walled prolapse? What are the symptoms? There is bulge, pelvic pressure, splinting, sexual dysfunction, and mixed urinary problems. How do you examine it? You have to do POPQ examination with point C in the mind. Also do occult SUI test, and imaging are seldomly required. What are the preventive or first line conservative options? Pessaries such as Gellhorn pessaries, which is a valid long-term strategy if the patient does not want to go for surgery or if it is very high risk. But remember, with that you have to ask the patient to do pelvic floor exercise. Let us discuss the surgical choices. First is abdominal or minimally invasive sacrocolpopexy. This is the durability benchmark for apical support. The Cochrane 2023 apical review concludes that sacrocolpopexy yields higher objective success than native tissue vaginal apical repairs, even with the mesh related risk and complication. Long-term care e-care cohort also shows excellent anatomical support, but mesh and suture erosion are around 7 to 10% by 7 years. So, concomitant urethropexy at the time of sacrocolpopexy lowers de novo stress urinary incontinence over long follow-up. Now let us talk about mesh. There is a mesh which is called as EPTFE, which is expanded polytetrafluoroethylene mesh. It is a microsporous and pores are too small for host tissue ingrowth and immune cell to penetrate. This leads to higher infection, poor integration, and much higher erosion exposure rates compared with polypropylene mesh. Because of this, EPTFE is not recommended in pelvic reconstructive surgery. So, take home message is always use lightweight macroporous polypropylene mesh for sacrocolpopexy and never use EPTFE kind of a mesh. Now, across the globe, regulatory bodies have acted decisively on vaginal mesh for prolapse repair. In United States, the FDA had halted all the sales in 2019. In UK, the MRHA replaced a national pause, later reinforced by the Kumberg report limiting mesh use only to the highly specialized center. Europe, Australia and New Zealand also followed the similar path, suspending or banning transvaginal mesh. Remember, we are talking about transvaginal mesh and not about abdominal or laparoscopically done sacrocolpopexy. Okay, so any procedure that you are doing with vaginally and using mesh is almost like no. So you should not go with transvaginal mesh repairs. And I'm not talking about TOTs or TVTs. Okay, so it's only about the mesh. So the next approach is native tissue vaginal apical suspension. Now, what is native tissue vaginal apical suspension? These are the tissues which are already present. That is, you restore the supports to the vaginal vault or cervix using the patient's own ligament and connective tissue without any prosthetic mesh. It is preferred vaginal approach for vault prolapse after hysterectomy or apical descent in uterovaginal prolapse. So remember, when we are doing abdominally, we are using mesh. When you want to do vaginally, then go with natural tissues. So what are the things that we can, what are the OTs that we can do? First is sacrospinous ligament fixation, where vaginal vault is sutured to the sacrospinous ligament, usually unilaterally and on the right side. What are the advantages? It is relatively easy. It avoids abdominal entry. What are the disadvantages? There is a deviation. Why? Because we are using only one side. Then there will be a deviation of the vaginal cuff. Then there is a risk of buttock pain and pudendal nerve injury. The second is uterosacral ligament suspension. Vaginal cuff is attached to uterosacral ligaments. Can be done intraperitoneally or vaginal approach. What are the advantage? It restores more midline access. What are the risks? There is a risk of ureteric injury, which is reported 1 to 10% of the time. Then there is the surgery which we do at the time of hysterectomy, that is macroculoplasty. That is plication of uterosacral ligament with closure of cul-de-sac. Preventive and therapeutic role for vault prolapse. What are the outcomes? What are the evidence that are there for this natural tissue repair? The success rate is 70 to 90%. Anatomical success at 5 years. What are the symptom relief? Most patient reports improved bulge symptoms, urinary and sexual function. What are the recurrence? Yeah, recurrence is there, but it is acceptable. It is higher than sacrocolpopexy. So sacrocolpopexy is the gold standard, especially when there is combined with anterior and posterior repair. What are the complications? See, when you do sacrospinous fixation, at that time there can be buttock pain and vault axis deviation. When you do uterosacral ligament suspension, there is ureteric kinking or injuries can happen. So in general, when you do a natural tissue repair, there is possibility of dyspareunia, recurrence in the anterior compartment. Now, uterosacral ligament suspension versus sacrospinous ligament fixation. The NIH optimal randomized trial shows no clinically important difference in composite surgical failure at 2 and 5 years. So, now we'll talk about what are the trade-offs that needs to be discussed for this. When you do uterosacral ligament suspension, ureteric proximity mandates meticulous suture placement and routine cystoscopy you need to do with this. When you do sacrospinous ligament fixation, you offset the vaginal axis. There can be a buttocks pain and there can be dyspareunia. Both are reasonable for sexually active patient preferring a vaginal native tissue route. So if patient doesn't want to do a mesh repair and wants to go with native tissue, then these are the options. Now there is one more option, that is obliterative option, which is if a patient is non-sexually active, frail or high-risk patient like old woman 70-75 years, then colpopexy offer a higher satisfaction and durability with shorter operative time and ensures patient understand that loss of coital function. Now there are two surgeries which are done laparoscopically, in which one of them is Pectopexy. What is Pectopexy? That is mass fixation to bilateral iliopectineal or Cooper ligament. Pectopexy anchors the vaginal or cervical apex to the iliopectineal ligament, which is Cooper's ligament on both the sides. The mesh passes across the anterior pelvis, giving anterior narrowing of the pelvic inlet. See, the pelvic inlet will narrow when you fix it on the upper side, as opposed to posterior narrow when you do a sacrocolpopexy. So, when you do sacrocolpopexy, there is a narrowing of posterior pelvis. When you do this surgery, then there is a narrowing of anterior pelvis. That's simple. So, why it is attractive? See, number one, it avoids presacral dissection. So there is no manipulation of presacral venous plexus, hypogastric nerve, or aorta or iliac vessels. It has a lower theoretical risk of catastrophic bleeding, bowel injury, or presacral neuropathy. By narrowing anteriorly, it preserves posterior pelvic space. So there is less risk of new onset constipation or obstructive defecation. See, if patient already has a constipation or defecation problem and you do a sacrocolpopexy, that might aggravate. So in those cases, you can go for this surgery, right? Now, when we compare the anatomical support of this surgery and sacrocolpopexy, almost there is similar data. There is reduction in the operating time and there is less blood loss in most laparoscopic series. Lower rate of de novo defectory dysfunction compared to sacrocolpopexy. Sexual function and quality of life are almost similar. So, both the procedures are good. Pectopexy seems like it is way better surgery than sacrocolpopexy. In some points, yes, it is great, it is good, but the disadvantage is it is very the data on Pectopexy is not that great. So still, if you want to consider, then the gold standard is sacrocolpopexy. What are the other points that are better in Pectopexy? Is the follow-up is shorter than the sacrocolpopexy. Right now there are lesser data on Pectopexy, but the data are emerging. So maybe in future there will be a change in the gold standard, right? Okay. Even in Pectopexy, surgeon experiences matters and learning curve can be steep. Okay. Now the next surgery is laparoscopic lateral suspension. And now what is laparoscopic lateral suspension? See, the concept is instead of fixing the mesh to sacrum or Cooper ligament like in Pectopexy, in lateral laparoscopic lateral suspension, we use a Y-shaped mesh that is placed on vagina, and the arms which are there, which are laterally that are fixed to abdominal wall near iliac crest. So we are bypassing the sacral promontory. So now, why it is useful? There is no sacral promontory dissection. So that is the first. And then adhesion prior surgery, if there is there, then it is better. If vascular anomalies you feel, then you should go for this surgery. If the sacral access is very difficult, like in obesity, then this surgery is better. Still the same thing, the data is less, so the gold standard becomes sacrocolpopexy. So now we go to the next topic, that is what documentation that are required, or medical legal documentation that you should have. Always record POP, POPQ, compartments treated, continence strategy, mesh counseling with the specific risks, alternative surgery such as uterosacral ligament fixation, sacrospinous ligament fixation, sacrocolpopexy, Pectopexy, LLS, and colpoclysis, and explain about what are the positive points and what are the negative points about particular surgeries. So the bottom line is always fix the apex first, always. If you don't anchor the apex, nothing else holds. Choose sacrocolpopexy when durability and vaginal axis preservations are the top priority and mesh is acceptable. If mesh is not acceptable, then uterosacral ligament fixation, sacrospinous ligament fixation for native tissue priorities. Consider Pectopexy or LLS when presacral dissection is undesirable or anatomy is hostile, and never miss the preventive step at the time of hysterectomy. That's all. Thank you.